Welcome to the UK contribution to this second Global Clinical Engineering Day 2017. The UK contribution will be a series of pre-recorded presentations and videos from representatives from around the UK as per below schedule. We hope you enjoy the next 1 hour. We have presentations from Richard Stubbs, Head of Medical Electronics Service, NHS Grampian in Scotland, from Jasdip Mangat, Head of Clinical Engineering at the University Hospital of Leicester in England, from Paul Lee, Medical Devices Training Manager from IPEM University Health Board in Wales, from Bazit Abdul, HCS Apprenticeship Programme Manager from Clinical Physics, Barts Health NHS Trust Royal London Hospitals, and from George Dempsey, Head of Clinical Engineering, Belfast HCS Trust from Northern Ireland.
Hello, my name's Richard Stubbs. I'm from NHS Grampian based in Aberdeen in Scotland. I'm the head of my organisation's Medical Electronics Service and also chair the Clinical Engineering Specialist Interest Group within the UK's Institute of Physics and Engineering in Medicine. I shall be talking about the IPEM or IPEM, which is our principal professional body here in the UK, and explaining how it contributes to and supports practice in clinical engineering. IPEM has 4 core roles. These are guiding assurance mechanisms that ensure that the public are protected when aspects of their care and well-being comes under healthcare science and engineering professionals. Getting involved with government and the work of governmental organisations and steering decision makers on professional matters requiring expert support. Providing a support network of professionals working in healthcare science and engineering, and working with the schools, educational establishments and institutions to inspire and promote interest in all aspects of our profession to bring new talent into health physics and engineering. IPEM oversees and supports physics and engineering healthcare professionals to both attain and to maintain the level of professional registration required by legislation and relevant professional guidance for them to practice safely, accurately and effectively in the UK. IPEM runs the Register of Clinical Technologists. It hosts a system of entry to the register and conducts monitoring and auditing of continual professional development or CPD activity for registered clinical technologists. This covers recording of learning activities, practice development and safe application of learning by practicing clinical technologists. IPEM publishes expert reports and journals. It publishes professional practice guidance, peer-reviewed journals and a professional magazine that takes topical contributions from its membership. IPEM funds audits and research projects. It provides prizes, awards and grants for innovation, travel, for professional ventures and learning opportunities for its members. It also provides information on grants and other funding opportunities from external organisations. A collection of reports have been developed by working groups under the Institute's Specialist Interest Groups. The collection illustrated here has been overseen by the Clinical Engineering Specialist Interest Group. IPEM publishes these international peer-reviewed scientific journals. The Institute publishes a quarterly professional members magazine called Scope that includes article contributions from its member base. IPEM endorses Biomedical Physics and Engineering Express, a broad, inclusive, online, rapid review journal devoted to publishing new research in all areas of biomedical engineering, biophysics and medical physics. IPEM is active in advising and lobbying key national and international decision makers, whose decisions affect safe and effective working through changes in political philosophy, demographics and economics. Members engage their collective professional knowledge and expertise to the writing of policy, standards, guidelines and legislation and to practicable delivery of services. The forums for doing this include parliaments and the devolved governments and assemblies in the UK. Europe and across the world. IPEM funds members to contribute their expertise and work with other partners and stakeholders, engaging through consultations, working groups and standards committees, etc. IPEM supports engineers through a range of professional activities and networking opportunities. These include a wide and comprehensive scientific meetings programme, CPD schemes for clinical scientists and clinical technologists and physiological science practitioners. There is a specialist interest group dedicated to clinical engineering. IPEM hosts engineering council registrations such as CEng, iEng and EngTech. A range of prizes, awards, bursaries, travel grants and innovation funding are accessible as enablers for its members, and peer-reviewed articles are published in IPEM's international journal Medical Engineering and Physics. IPEM specialist interest groups play a vital role in overseeing scientific activity in particular topic areas. They provide a body of expertise on their specific areas of science or engineering within the Institute. Their contribution includes planning and delivering a programme of scientific and educational meetings, producing authoritative publications, monitoring the development and impact of new technology, monitoring and contributing to development of relevant standards and legislation, commenting on workforce issues and impact of policy changes in their area of endeavour, encouraging and developing evidence-based practice, encouraging liaison between members working in different working environments, for example academia, industry and hospitals, and supporting and encouraging relevant educational programmes. IPEM currently has 12 specialist interest groups covering these topic areas. The Clinical Engineering Specialist Interest Group, or CESIG, oversees engineering activity within the field. It meets 3 times a year to review its activity plan. The Clinical Engineering Specialist Interest Group has been active in setting up topical professional meetings aimed at helping clinical engineering professionals to build upon current aspects of their practice. Here are some examples of recently conducted events and events in planning. These meetings offer excellent opportunities for both members and the wider audience connected with IPEM stakeholders to contribute to the collective knowledge within the profession by presenting their work and sharing their expertise. For delegates attending, besides the obvious learning opportunity, these events help form professional relationships and forge networks between people working in the field, nationally and across the rest of the world. The Clinical Engineering Specialist Interest Group has recently been involved with developing these publications. In regard to inspiring the next generation of engineers, IPEM has been active in engaging with young learners through these events and resources. More details of these can be sourced directly from the Institute. It's really important that we promote opportunities that get school-aged children interested in science, technology and medicine in order to improve the numbers of medically specialised engineers in the future and to build practicable and accessible entry routes for them into the profession. IPEM is an organisation that is made up predominantly from its members and relies on their professional activity to be effective. It serves to coordinate the collective effort of its members with input and peer support from its numerous stakeholders. If you are interested in becoming a member of IPEM or getting involved with its work, or are interested in working with its clinical engineering or other specialist interest groups, please go to IPEM's website at www.ipem.ac.uk for more information. Thank you for watching.
Hello, my name's Mr. Jasdip Mangat. I'm the Head of Clinical Engineering at the University Hospitals of Leicester NHS Trust and also the Academy of Healthcare Science Professional Lead for Clinical Engineering. I'm going to talk about registration of clinical engineers in the UK. Within the UK, there are three main groups of professionals that work in the field of clinical engineering. These are clinical scientists, clinical technologists or healthcare science practitioners, and healthcare science associates and assistants. There may be others, however, these are the main areas and make up a significant portion of the workforce within clinical engineering departments within the UK, with clinical technologists or healthcare science practitioners making up the majority. When talking about professional registration, this mainly applies to clinical scientists and clinical technologists or healthcare science practitioners. Within the UK, the registration landscape has significantly changed over recent years. This slide shows the registration bodies in the UK for clinical engineers as it currently stands. The Academy of Healthcare Science is the overarching body for the whole of healthcare science profession in the UK. It was commissioned by the Health Education England in September 2011. The Health and Care Professions Council is a regulator and was set up to protect the public. To do this, they keep a register of all health and care professionals who meet their standards, such as standards for training, professional skills and behaviours. The Register of Clinical Technologists, or the RCT, was formerly known as the Voluntary Register for Clinical Technologists and was formed in 2000. The RCT consists of representatives from IPEM in partnership with the ART, which is the Association of Renal Technologists, and IPEM, which is the Institute of Healthcare Engineering and Estates Management. The Engineering Council is the UK regulatory body for the engineering professions. It is not specific to healthcare. They hold a national register for engineering technicians, incorporated engineers and chartered engineers. The Science Council is a membership organisation. The Science Council holds the national register for registered science technicians, registered scientists and chartered scientists. This next slide shows the different routes to registration for clinical engineers in the UK. The blue lines indicate direct entry registration through structured training programs, whereas the red lines indicate registration through equivalence routes. The National School of Healthcare Science run two structured training programs. One called the STP, which is the Scientific Training Programme, where on completion students become registered under the HCPC as a clinical scientist. With the PTP route, students become registered under the Academy of Healthcare Science as a healthcare science practitioner. IPEM also run a structured training programme for healthcare technologists, as well as the ART, which is the Association of Renal Technologists. Students completing an ART or IPEM clinical technologist training course can become registered under the RCT as a clinical technologist. In terms of equivalence, the Academy of Healthcare Science have equivalence programs for both practitioners and scientists. This is where candidates will need to submit a portfolio of evidence indicating how they meet all the criteria of a healthcare clinical scientist or a healthcare science practitioner. IPEM also run equivalence route, where candidates can submit a portfolio of evidence. They have to meet certain objectives and submit that portfolio to the Association of Clinical Scientists. An oral examination will then be conducted to assess whether that candidate meets the criteria, and on completion, successful completion, the candidate can be registered under the HCPC register as a clinical scientist. So how well are the clinical engineering registered regulated? The Professional Standards Authority for Health and Social Care are accountable to the UK Parliament. Their job is to scrutinise and oversee the work of 9 health and care regulators, As you will see, the HCPC, who is the Register for Clinical Scientists, are a statutory regulator, and hence it is a criminal offence to work as a clinical scientist in the UK unless you are on the HCPC register. The Professional Standards Authority also accredits voluntary assured registered of people working in a variety of health and social care occupations, where occupations are not subject to statutory regulation like the HCPC and clinical scientists. The accredited voluntary register scheme allows people to choose practitioners who are on a register that has been independently assessed and approved by the Professional Standards Authority. Both the Academy of Healthcare Science and the RCT are PSA accredited assured registers, which means it is not currently statutory to be on the register to practice as a clinical technologist or a healthcare science practitioner. The Academy of Healthcare Science covers a wide range of healthcare science professions in the UK, across life sciences, physiological sciences and physical sciences and informatics. The specific ones relating to clinical engineering are biomechanical engineering, clinical measurement and development, equipment management and clinical engineering, medical electronics and instrumentation, medical engineering design, rehabilitation engineering, renal dialysis technology. The RCT specialisms are much more specific to physics and engineering, and as you see, under clinical engineering the specialisms are medical engineering, radiation engineering, rehabilitation engineering and renal technology. So why is it not statutory to work as a healthcare science practitioner or a clinical technologist in the UK? Well, this goes back to 2011, where the government wrote a command paper titled Enabling Excellence, Autonomy and Accountability for Health and Social Care Staff. In the paper it said the government will only consider extending statutory regulation, including to groups in the healthcare science workforce where there is a compelling case on the basis of public safety, risk and where assured voluntary registers are not considered sufficient to manage this risk. As such, so if it's not statutory, why is it important to be registered? Well, it is becoming increasingly viewed as essential by employers, providers and commissioners, and as well as patients themselves. Through registration, an individual shows commitment to upholding high professional standards and to keeping their knowledge, skills and experience up to date through ongoing professional development. If individuals fail to uphold the standards and show they are fit to practice, then they can have their registration status restricted or removed. So what are the benefits to me of being registered as a clinical engineer in the UK? In addition to the patient safety benefits, the risk reduction and arguably the higher quality workforce, some of the personal benefits to the applicant are many of the hospitals today with clinical engineering vacancies are putting this as a mandatory requirement in job descriptions, hence there's greater competition for jobs. There's also the personal achievement and status benefits that would come with having registration. Good scientific practice is a document written by the Academy of Healthcare Science and sets out the principles and values on which good practice undertaken by the healthcare science workforce is founded. Both STP and PT curriculums are very much based around the 5 main domains of good scientific practice. These are professional practice, scientific practice, clinical practice, research, development and innovation, and clinical leadership. The RCT equivalence applications must show that this document has been read, understood, and that applicants adhere to it in their daily role. So looking forward, where are we going with registration for clinical engineers in the UK? Well, the RCT and the Academy of Healthcare Science are going to continue with their objective of making registrations for practitioners and technologists statutory in the UK. There may become closer collaboration from both the Academy of Healthcare Science and the RCT register going forwards. It might become standard practice to have the requirement for registration in job descriptions for practitioner and technologist posts going forward. And going on from there, as people become registered and take registration more seriously, there may become greater applications for other professional qualifications such as the Engineering and Science Council registrations, as we discussed earlier, such as the RSci, the EngTech, the iEng or the CEng qualifications.
Hello everyone, my name is Paul Lee and I'm a medical device training manager working in Morriston Hospital in Swansea in Wales in the United Kingdom, and my presentation is focused on the role of the medical device safety officer and how we help contribute towards incident reporting and learning. Now, when a patient is harmed or could have been harmed due to an incident involving a medical device, it is vital that it gets reported to help improve patient safety. To improve medical device incident reporting and learning, NHS England and the MHRA issued a joint patient safety alert in March 2014 asking providers to identify a named medical device safety officer or an MDSO. So this role was established in the United Kingdom in March 2014. A Stage 3 directive was issued from NHS England and the MHRA asking people to improve medical device incident reporting and learning. NHS Improvement have subsequently gone on to develop an interactive and learning website where all incidents can get reported and lessons can also be learnt. The Medical Device Safety Officer Network consists of two key parts. Medical devices are covered by the Medicines and Healthcare Regulatory Agency, the MHRA, and patient safety issues in the United Kingdom are looked at by NHS Improvement, based in London. Now, patient care is delivered by NHS providers such as NHS hospitals, NHS trusts, etc. And we gather in reported incidents via the National Learning Reporting System, the NRLS, and we currently record approximately 2 million incidents per annum. Within their organisations, the role of the Medical Device Safety Officer is to promote safe use of medical devices, to encourage incident reporting at all levels across the organisation, to provide expert advice for those asking for help, and to serve as the essential link for identification of risks and concerns surrounding medical devices. They also have an important role in supporting the implementation of local and national safety initiatives such as patient safety alerts and notices. Key to the success of building a community for medical device safety officers is a national community, and we currently have representation from all countries across the United Kingdom that link into this network. Participation is also important, and people get involved in different levels, from contributing towards alerts to carrying out surveys. MDSOs also offer valuable insight. They usually have a range of experiences from clinical engineering to medical device management and know how these devices should be used or shouldn't be used, and that can help contribute towards outcomes from patient safety investigations. The most important factor with the MDSO is the monthly WebEx meetings. Medical device safety officers get together every month to review current issues, and they could literally be just a few days old, where we can share learning, ask for help and assistance, and help MDSOs to take back important messages to their organisations. The Medicines and Healthcare Regulatory Agency, National NHS Improvement Patient Safety also contribute towards these WebExes. The role of an MDSO is varied, and currently within the UK there are 350 signed up medical device safety officers, and they've discussed, debated and shared information around 40 key subjects since March 2014. If you wish to become an MDSO, then there's a registration process which I'll cover towards the end of this presentation, and the vast majority of MDSOs are either medical device engineers, clinical engineers, there's some nursing staff, clinical governance staff, and medical device managers. The range of subjects covered on the monthly WebEx is quite vast. You can see from the list in front of you. We've had presentations on the update on GS1 barcoding, presentations on medical device user manuals and pitfalls. The CAS or Central Alerting System has been covered and how you register and how you report incidents across the United Kingdom, point-of-care testing and self-test blood glucose monitors, and the National Health Service Master Indemnity Process, a legal liability process covered by manufacturers putting equipment out on loan. We've also discussed and debated medical device time clock settings and whether they should be kept in Greenwich Mean Time or British Summer Time to avoid confusion for users. We've looked at non-automatic weighing instruments and patient weighing devices and the way that they are weighed differently in organisations. We covered recently the company's reps credentialing review, which looks at how we manage visitors, especially reps from medical device industries when they come into hospitals, and how we control their access to patients and patient care areas. A general topic that we cover from time to time is the new international standard on small bore connectors, ISO 80369, and we've shared information around enteral feeding connectors, and more recently the alert that was issued from NHS Improvement on neuraxial connectors for intrathecal and epidural infusions. We've covered good practice for patient safety investigations and how to carry these out, and analysis for medical device related incidents. We've looked at supply disruption alerts, and we've had presentations on the importance of medical device training. Recently, new guidelines in the UK came out, or in Europe actually, for medical device regulations. They were also covered, and also the value of multiple reporting sources for in vitro diagnostic devices. The Medical Device Safety Officer acts as an important link between users and the MHRA and NHS Improvement. They liaise with other medical device safety officers and get involved in developing audits of use and safety, and also in surveys to gauge opinion before progress is made on patient safety alerts. MDSOs also get involved in developing and writing reports and sharing that information both locally and nationally amongst the MDSO network. So if you wish to become a medical device safety officer, then you need to become nominated by your organisation, and usually there's only one MDSO login per employer. You can access the forms through the safety alerts at dh.gsi.gov.uk website. And then you'll be able to log in for the forum where you can discuss issues of concern and get access to WebExes which are recorded monthly. You will then be added to the National MDSO list, and you will receive an email each month on how to log into the webinar or the WebEx. You'll also be invited to come to the annual MDSO Patient Safety Conference, which happens in April each year. An additional resource that the MDSO network can link into is the new National Association of Medical Device Educators and Trainers, or NAMDET. This organisation publishes a regular journal where NHS Improvement and the MHRA share important messages, share updates on patient safety alerts, and the Medical Device Safety Officer also contributes towards articles within this journal. So thank you very much for listening to me, and I hope in just a few minutes I've managed to outline the role of the medical device safety officers in the United Kingdom and the important role that they have in incident reporting and learning. And where a patient is harmed or could have been harmed due to an incident involving a medical device, it is vital that it is reported to help improve patient safety, and the role of the medical device safety officer is key to this improvement. Thank you very much.
Barts Health is a very large trust. It's a teaching hospital, as well as providing services to 5 sites. So it's a very major trust in the whole of the UK and provides services to all across East London and right out to the East Coast, and has referrals from all over the country. Medical physics and clinical engineering provide scientific and technical support to virtually every clinical patient pathway within the organisation. The major features of that support is scientific support through the support of the radiotherapy processes, which is the treatment of patients with cancer, through nuclear medicine, physics, which is the support of patients undertaking nuclear medicine investigations and diagnostics, through radiation safety, which is a team which is dedicated to the safe use of radiation of both members of staff and the public as they pass through Barts Health. And then I guess the last major group within physics is clinical engineering, and clinical engineering take responsibility for all the medical equipment within the organisation across all these sites, with a few exceptions which of course are under different contractual arrangements, but by and large the entire medical equipment stock of equipment for this organisation is managed through clinical engineering.
So as an overview, the clinical engineering department at Barts Health consists of 4 teams based at each site. So we have trained medical engineers on each site. They look after the day-to-day running of all medical equipment. We have a training team based here at the Royal London Hospital which covers all the sites. We have a contracts management team, and we also have a governance lead who supports our clinical engineering team.
I manage the maintenance contracts for medical devices throughout the Barts Health Trust. I would say that contracts are kept up to date and are well managed, which in turn ensures that medical devices are maintained properly to the manufacturer's specifications. And this helps to ensure that medical procedures are carried out correctly and safely for both patient and staff.
So this in essence is to ensure that all medical devices within the Trust and in patient use are available, they are safe and they are regularly maintained, and we have a number of ways in achieving that, and these are externally audited. My other role is to act as the MDSO, which is the Medical Devices Safety Officer for the Trust, and this is working with outside organisations such as the MHRA and the manufacturers to ensure that any faults, both on patients as well as identified by vigilance into the Trust, are managed so that equipment stays safe throughout its life.
I'd like to think that my job role here has a positive effect on the care of the patients that we give here on the Adult Critical Care Unit. Myself and my team are responsible for making sure that the equipment is available for the staff when they want it, and I really hope that that's what I can contribute to this unit. Although I don't work on the coalface, the things that I do actually do make a difference to patient care in the end.
My day-to-day activities included PPM repair, acceptance test, Mangat testing for all imaging systems in the 5 major hospitals in London area.
To resolve the daily challenges that we face, first of all, I think we need to have a fresh mindset, be positive, optimistic that every day is going to be a better day. For that reason, I think that the best contribution for clinical engineers is to make sure that our engineers are fully qualified, they attend training on a regular basis, that we offer the right facilities in our department. When there are challenges, we need to highlight those challenges to our seniors managers, or in conjunction with them we can work out solutions.
Today I'm required to ensure that we are planning our equipment training for our staff across the sites, that we are delivering some of the training, and that we are liaising with our company trainers to ensure that when equipment needs to be, staff need to be updated on equipment training, that they can work with us to ensure that this happens.
The impact of my role on patient care is very, very important. At the end of the day, the hospital relies on anaesthesia equipment in the main operating theatres. So, you know, if there's a problem with these, we need to make sure that they're high risk, and they're high risk equipment, and they're high priority to get them turned around, so we don't have machines out of service. We want more equipment in service. So patients always come first in this situation. So we always try to aim to use that motto in everything we do.
Okay, so I do a healthcare science apprenticeship. So I shadow my senior colleagues when they are servicing and repairing equipment. I also attend college for extra education into the engineering field.
I enjoy my role because it involves an extensive engagement with a wide range of stakeholders, and secondly, the output of my work is producing a clear pathway for the clinical engineering workforce of the future. The major challenge is the lack of awareness about clinical engineering role among students, teachers and parents. This makes it difficult to recruit high caliber, technical minded apprentices for clinical engineering departments.
Resources with regards to training is vitally important, but for me, the main resource is actually promoting ourselves. I think we need to have a stronger profile in the medical profession, and I feel that we don't promote ourselves enough. And hopefully, this small little acorn of promotion today will eventually become a very big oak tree in the future.
Every day is different challenge for us, and I enjoy to work with the variation of this work. I also enjoy the moment when we fix the system and user came with the big smile in their face and say thank you to us.
I enjoy my role on a daily basis by working with a very young, effective team members. I guess technology and the growth within our department makes me enjoy coming to work and teach and show others what I've learned so that they could be the next generation coming forward. Other than that, on my basis, I like to actually problem solve and deal with scenarios that need to be solved in quick periods of time. So having a solution quick to any problem is part of my daily activities, and problem solving and routine servicing. So I guess I enjoy my work by others being around me and my challenges on a daily basis.
Well, I like fixing things and I like solving problems, and clinical engineering allows me to do this, and it's something I really love to do.
The Belfast Trust is the largest group of hospitals in Northern Ireland. Clinical engineering supports a range of activities including equipment management, clinical computing, clinical measurement, rehabilitation engineering and bioengineering research and development. These activities are delivered through a mix of registered clinical scientists, clinical technologists and biomedical engineers. A short video highlights the work of a clinical engineer involved in the clinical motion analysis of patients requiring orthopaedic and medical intervention.
Some of the skills required of a clinical engineer in a clinical gait analysis setting include the ability to capture, process and analyze three-dimensional motion capture data, perform quality control processes and interpret the clinical significance of the outcomes along with clinical measurements of strength, muscle tone and motor control selectivity. The gait analysis engineer is part of a multidisciplinary team of orthopedic and neurology consultants and physiotherapists. The Regional Gait Analysis Laboratory in Northern Ireland is located in Musgrave Park Hospital in Belfast. Its equipment includes a Vicon motion analysis system with 8 infrared and 2 video cameras and 2 AMTI force plates for detailed analysis of gait kinematic and kinetic patterns. Retroreflective markers are placed on anatomical landmarks to describe rotational and translational movement of the pelvis, femora, tibia and feet in a three-dimensional space. A static trial is initially used to build a 3D model for the lower limbs based on the anatomical position of the markers and anthropometric measurements. Dynamic trials are processed first by labeling the markers and segmenting the trial to eliminate non-usable data. A quality check is performed to determine whether all markers are labeled and visible throughout the trial. The quality panel indicates which markers were not labeled and which marker trajectories have gaps throughout the trial. Missing markers are reconstructed based on the position and movement of markers within the same segment. The quality check panel is used to ensure all gaps are filled and all markers are labeled. The trial is then processed to filter noise from marker trajectories and force plate data. Gate events of foot contact and foot off are determined using the force plate data. Further gate events are calculated based on the position of the heel marker as they were making contact with the force plates. A dynamic model is then generated by detecting the center of rotation of the joints during walking. A report generating software is used to bring several trials and check the repeatability for the kinematic and kinetics. A representative trial is then selected to analyze the kinematic and kinetic patterns of the left and the right legs together. The 3D model is superimposed on the video to verify marker placement accuracy subjectively. A final quality check is performed to ensure the position of the markers on the thigh is adequate, using the coronal plane knee data. If the thigh marker is not positioned correctly, it will give an erroneous measurement of hip rotation. For example purposes, if we introduce an artificial error on the thigh marker position, the hip rotation error can be detected by crosstalk between the knee, coronal, and sagittal data. In this particular example, I have introduced an excessive external rotation at the right hip and excessive internal rotation at the left one. By using a correcting factor on the thigh marker position, we can improve the quality of the hip rotation outcome. However, in routine practice, errors in the thigh marker placement are minimized by physiotherapists, thus reducing the need for this correction. Force plate and kinematic data are used to calculate moments and powers around the joints, which give us an estimation of the amount of work done by different muscle groups as a whole. This is only an estimation, as the force plate can give us resultant forces, but do not provide information on individual muscle forces.